Welcome to our series of COVID-19 webinars. We have created 4 so far to help understand more about this disease and the effects on patients. Please feel free to access all 4 webinars at a time which suits you. In Part 3, we will reflect on what we have learnt so far about COVID-19 since its first appearance. Nearly every country in the world has been affected by COVID-19 in one way or another, and this has caused an influx of scientific publications, correspondence, educational webinars, and clinical guidelines on how to look after the people who have contracted the disease. Due to the ever-growing amount of publications related to COVID-19, we can examine what has been learnt so far regarding the characteristics of the patients contracting the disease, the pathogenesis of the disease, and some of the outcomes from the disease. More men than women become infected. There is a higher percentage of deaths in Black, Asian, and minority ethnic groups. Older people are more susceptible to contracting the disease. Anyone with existing comorbidities or living in care homes, and interestingly, if living in areas of deprivation, seem to be more susceptible. If patients require ventilation support, the statistics do not look favourable, with a high mortality associated with these patients. And initially, it was thought that children were not affected, but recent publications are now stating that there seems to be a surge in some countries where small numbers of children are showing an inflammatory type illness that could be their response to the SARS CoV-2 virus. And both the World Health Organization and the Centre for Disease Control have added some more signs and symptoms of COVID-19. From the publications, these include loss of smell and taste, having a cough, fever or chills, a sore throat, any unusual tiredness, a headache, new rashes on the toes or fingers, and diarrhea in some cases. This is a cohort study performed in the UK looking at the electronic health records of over 17 million people. Within that group, the hospital deaths from COVID-19 over a certain time period were looked at. The time commenced from the 1st of February, which was before the first case of COVID-19 was identified in the UK. There were 5,683 deaths attributed to COVID-19. In summary, after full adjustment, death from COVID-19 was strongly associated with being male, older age, and deprivation, both with a strong gradient, uncontrolled diabetes, severe asthma, and various other prior medical conditions. Compared to people with ethnicity recorded as white, Black people were at a higher risk of death, with similar findings for Asian people. Commentators and researchers have reasonably speculated that this might be due to higher prevalence of medical problems, such as cardiovascular disease or diabetes among BME people, or higher deprivation. Our findings, based on more detailed data, show that this is only a small part of the excess risk. Other possible explanations for increased risk among BME groups relate to higher infection risk, including overrepresentation in frontline professions with higher exposure to infection or higher household density. Deprivation is also a major risk factor, with, again, little of the excess risk explained by comorbidity or other risk factors. We also found a consistent pattern of increasing risk with greater deprivation, with the most deprived quintile having an HR of 1.75, compared to the least deprived, consistent with recent national statistics. Again, contrary to prior speculation, very little of the increased risk associated with deprivation was explained by pre-existing disease or clinical risk factors, suggesting that other social factors increase the risk of COVID-19 infection or death from infection. COVID-19 and the cardiovascular system. Implications for risk assessment, diagnosis, and treatment options. Cardiovascular Research Review, DOI:10.1093/CVR/CVAA 106-2nd June 2020. Cardiovascular involvement in COVID-19, key manifestations and hypothetical mechanisms. SARS CoV-2 anchors on transmembrane ACE2 to enter the host cells, including type 2 pneumocytes, macrophages, endothelial cells, pericytes, and cardiac myocytes, leading to inflammation and multi-organ failure. In particular, the infection of endothelial cells or pericytes could lead to severe microvascular and macrovascular dysfunction. Furthermore, in conjunction with the immune overreactivity, it can potentially destabilize atherosclerotic plaques and explain the development of the acute coronary syndromes. Infection of the respiratory tract, particularly of type 2 pneumocytes by SARS CoV-2, is manifested by the progression of systemic inflammation and immune cell overactivation, leading to a cytokine storm, which results in an elevated level of cytokines such as IL-6, IL-7, IL-22, and CXCL10. Subsequently, it is possible that activated T cells and macrophages may infiltrate infected myocardium, resulting in the development of fulminant myocarditis and severe cardiac damage. This process could be further intensified by the cytokine storm. Similarly, the viral invasion could cause cardiac myocyte damage, directly leading to myocardial dysfunction and contribute to the development of arrhythmia. Sometimes the body's response to infection can go into overdrive. For example, when SARS CoV-2, the virus behind the COVID-19 pandemic, enters the lungs, it triggers an immune response, attracting immune cells to the region to attack the virus, resulting in localized inflammation. But in some patients, excessive or uncontrolled levels of cytokines are released, which then activate more immune cells, resulting in hyperinflammation. This can seriously harm or even kill the patient. Cytokine storm, also known as high cytokine disease, is the systemic expression of a healthy and vigorous immune system, resulting in the release of more than 150 inflammatory mediators such as TNF-alpha, IL-1, IL-6, IL-12, IFN-alpha, IFN-beta, IFN-gamma, MCP1, and IL-8. Both pro-inflammatory cytokines and anti-inflammatory cytokines are elevated in the serum, and the fierce and often lethal interplay of these cytokines is referred to as a cytokine storm. It is a severe excessive immune response caused by a positive feedback cycle between cytokines and immune cells. The symptoms are high fever, redness, swelling, extreme fatigue and nausea, which can be fatal in some cases. Cytokine storm is an important cause of acute respiratory distress syndrome and multiple organ failure. There seems to be something happening to children who are maybe exposed to the virus. There are 4 cases presented here which appear to have similar characteristics. On May the 6th, a letter was published in The Lancet concerning hyperinflammatory shock in children suddenly being seen in a hospital in London. 10 children were admitted to the hospital. The article goes on to quote the following: "The intention of this correspondence is to bring this subset of children to the attention of the wider pediatric community and to optimize early recognition and management. We suggest that this clinical picture represents a new phenomenon affecting previously asymptomatic children with SARS CoV-2 infection manifesting as a hyperinflammatory syndrome with multi-organ involvement similar to Kawasaki disease shock syndrome." As this correspondence goes to press, 1 week after the initial submission, the Evelina London Children's Hospital Paediatric Intensive Care Unit has managed more than 20 children with similar clinical presentation, the first 10 of whom tested positive for antibody. On May the 13th, this publication emerged from the Italian epicentre of the SARS CoV-2 epidemic. In the past month, we found a 30-fold increased incidence of Kawasaki-like disease. Children diagnosed after the SARS CoV-2 epidemic began showed evidence of immune response to the virus, were older, had a higher rate of cardiac involvement, and features of MAS, macrophage activation syndrome. The SARS CoV-2 epidemic was associated with high incidence of a severe form of Kawasaki disease. A similar outbreak of Kawasaki-like disease is expected in countries involved in the SARS CoV-2 epidemic. On the 20th of May 2020, the CDC added this concern of hyperinflammatory responses with children on their website. On May the 13th, another publication reported from Washington, D.C., 177 patients were diagnosed as COVID-19 positive. Of the 177 pediatric and young adult SARS CoV-2 infected patients, 44 of 177 patients, 25%, required hospitalization, of which 35 of 44, 80%, were non-critically ill, and 9 of 44, 20%, were critically ill. Children under 1 year of age and children or young adults under 15 years of age each represented 32%, 14 of 44, of all hospitalized patients, accounting for a total of 64% of hospitalizations. Adolescents and young adults under 15 years of age represented 66%, 6 of 9, of critical care admissions. On May the 20th, the CDC highlighted some interesting cases from New York. During March and April, cases of COVID-19 rapidly increased in New York City and New York State. In early May 2020, the New York City Department of Health and Mental Hygiene received reports of children with multi-system inflammatory syndrome. From April the 16th through May the 4th, 2020, 15 patients aged 2 to 15 years were hospitalized, many requiring admission to the intensive care unit. As of May the 12th, 2020, the New York State Department of Health identified 102 patients, including patients from New York City, with similar presentations, many of whom tested positive for SARS CoV-2 infection by RT-PCR or serologic assay. New York State and New York City continue to receive additional reports of suspected cases. Additional reports of children presenting with severe inflammatory syndrome with a laboratory-confirmed case of COVID-19 or an epidemiological link to a COVID-19 case have been reported by authorities in other countries. Some consistent characteristics have been reported about patients contracting COVID-19 and their outcomes. This retrospective case series from Italy reported on 1,591 patients in the March timeframe that were critically ill. 99% of these patients required respiratory support, and ICU mortality was 26%. Some of the common characteristics here were older men in the population and high levels of PEEP delivered during ventilation. In this case series from New York, the most common comorbidities seen in patients with COVID-19 were hypertension, obesity, and diabetes. The findings of high mortality rates among ventilated patients are similar to smaller case series reports of critically ill patients in the US. The big question seems to be, why are some of these critically ill patients dying? Now that we have some data from all of these published case series, this can be explored. One study reported that the current management guidelines for COVID-19 reflect the assumption that critically ill patients infected with SARS CoV-2 develop acute respiratory distress syndrome, ARDS. However, emerging data and clinical reports increasingly suggest an alternative view that severe COVID-19 reflects a confluence of vascular dysfunction, thrombosis, and dysregulated inflammation. Another study stated that reports of increased respiratory dead space suggest lung vascular thrombosis from thrombotic microangiopathy or pulmonary embolism. The latter was recently reported in up to 40% of hospitalized COVID-19 patients. From the Gattinoni group, they were seeing something quite different happening to their patients. The Surviving Sepsis Campaign panel recently recommended that mechanically ventilated patients with COVID-19 should be managed similarly to other patients with acute respiratory failure in the ICU. Yet, COVID-19 pneumonia, despite falling in most of the circumstances under the Berlin definition of ARDS, is a specific disease whose distinctive features are severe hypoxemia, often associated with near-normal respiratory system compliance. More than 50% of the 150 patients measured by the authors and further confirmed by several colleagues in northern Italy. This remarkable combination is almost never seen in severe ARDS. Therefore, the same disease actually presents itself with impressive non-uniformity. Understanding the correct pathophysiology is crucial to establishing the basis for appropriate treatment. Between March 3rd and March 31st, 2020, all patients referred for ARDS due to SARS CoV-2 were prospectively included on admission in 4 intensive care units, ICUs, in 2 centres of a French tertiary hospital. These are some of the details that they discovered. Comparison between 145 non-COVID-19 ARDS patients and 77 COVID-19 ARDS patients. The COVID-19 patients developed significantly more thrombotic complications, mainly pulmonary embolisms. Coagulation parameters significantly differed between the 2 groups. 64 clinically relevant thrombotic complications were diagnosed in 150 patients during their ICU stay, mainly pulmonary embolisms. They concluded that despite anticoagulation, a high number of patients with ARDS secondary to COVID-19 developed life-threatening thrombotic complications. Higher anticoagulation targets than in usually critically ill patients should therefore probably be suggested. Over a 2-week period from March 23rd to April 7th, 2020, a total of 5 patients who were younger than 50 years of age presented with new onset symptoms of large vessel ischemic stroke. All 5 patients tested positive for COVID-19. By comparison, every 2 weeks over the previous 12 months, our service has treated, on average, 0.73 patients younger than 50 years of age with large vessel stroke. The association between large vessel stroke and COVID-19 in young patients requires further investigation. Social distancing, isolation, and reluctance to present to the hospital may contribute to poor outcomes. 2 patients in our series delayed calling an ambulance because they were concerned about going to a hospital during the pandemic. Classification of the cutaneous manifestations of COVID-19. A rapid prospective nationwide consensus study in Spain, with 375 cases, published April 2020. 429 cases from the 3rd to the 16th of April 2019, during the peak of the epidemic in Spain. Final sample included 375 patients. All patients with an eruption of recent onset, previous 2 weeks, and no clear explanation, plus suspected, patients presenting with compatible symptoms, or confirmed COVID-19, with laboratory confirmation of SARS CoV-2, irrespective of clinical signs and symptoms, using the definitions of the European Centre for Disease Control, were included. It is unusual, from our previous experience with cutaneous manifestations of viral diseases, that a single virus can lead to several different clinical patterns, especially as different patterns do not coexist on the same patient. 5 cases were excluded for being compatible with other diagnoses: 3 herpes zoster and 2 psoriasis. 31 patients with cutaneous lesions were excluded for not meeting the definition of confirmed or suspected COVID-19 and 18 for missing information. From the recent data, there seems to be effects on other organs than the lungs. From some of these reported cases, clinicians are now wondering if COVID-19 could be a blood vessel disease. All of these COVID-associated complications were a mystery. We see blood clotting, we see kidney damage, we see inflammation of the heart, we see stroke, we see encephalitis, swelling of the brain, says William Lee, MD, president of the Angiogenesis Foundation. A whole myriad of seemingly unconnected phenomena that you do not normally see with SARS or H1N1, or frankly, most infectious diseases. If you start to put all of the data together that's emerging, it turns out that this virus is probably a vasculotropic virus, meaning that it affects the blood vessels, says Mandeep Mehra, MD, Medical Director of the Brigham and Women's Hospital Heart and Vascular Center. So what is COVID-19 actually doing to patients? Well, some clinicians believe a cytokine storm is being created. A cytokine storm is an overreaction of the body's immune system. In some people with COVID-19, the immune system releases immune messengers, called cytokines, into the bloodstream, out of proportion to the threat or long after the virus is no longer a threat. When this happens, the immune system attacks the body's own tissues, potentially causing significant harm. A cytokine storm triggers an exaggerated inflammatory response that may damage the liver, blood vessels, kidneys, and lungs, and increase formation of blood clots throughout the body. Ultimately, the cytokine storm may cause more harm than the coronavirus itself. A simple blood test can help determine whether someone with COVID-19 may be experiencing a cytokine storm. Trials in countries around the world are investigating whether drugs that have been used to treat cytokine storms in people with other non-COVID conditions could be effective in people with COVID-19. We are still learning from the COVID-19 disease. On a global level, the disease has reached most countries all at different times, and here we can see many different strategies in place. China would appear to be ahead of other countries such as Europe, North and South America. We need to learn from them and see if their strategy works better than others. We also need to brace ourselves for any further outbreaks of the virus.